In this, our final video, I'll discuss doctor-patient communication. Okay, so I want to start by going over a few background issues in the area of doctor-patient communication. The doctor-patient relationship is very complicated. It involves an interaction with individuals who are in non-equal positions. It's often non-voluntary. It concerns very important issues, even life and death issues. It's emotionally laden, and it requires close cooperation. So first, what are the purposes of doctor-patient communications? Well, there are three main purposes: creating a good interpersonal relationship, exchanging information, and making medical decisions. Creating a good interpersonal relationship is considered a prerequisite for optimal care. But how do you define a good relationship? What are the features? Well, first, it's a social relationship. So things that matter in any relationship matter here too. Both parties should exercise good manners, and the doctor should convey interest, remain non-judgmental, and show a desire to help the patient. It should also have therapeutic qualities. The doctor should show empathy, and both parties should be respectful, genuine, and trusting. Finally, the ideal relationship should be one in which each person leads the area where he or she is the expert. The patient is the expert on the patient's symptoms, feelings, and behaviors, and the doctor is the expert on medical information, such as diagnosis and treatment. The second purpose of doctor-patient communication is to exchange information. Doctors need information about their patient's symptoms so that they can come up with a diagnosis. Patients need to know and understand what's wrong with them and what to do about it. Doctors seem to underestimate how much information patients want. In one representative study, 92% of cancer patients wanted their doctor to give them all of the possible information they could get, whether it was good or bad, but only 45% said their doctor had given them all the information they wanted. Frequently, doctors withhold information from cancer patients because they fear that total disclosure will cause negative emotional reactions in their patients. Doctors' own negative emotions may also cause them to be reluctant to fully inform their patients. One study looked at whether doctors told their patients their prognoses. In the study, the researchers looked at cancer patients who were entering a hospice, meaning that they weren't expected to recover. They found that doctors wouldn't tell their patients their prognosis 23% of the time. 37% of the time they gave patients a frank and realistic prognosis, and 40% of the time they gave a more optimistic prognosis. Now, how accurate were these prognoses? Well, the patients actually lived a median of 26 more days. The doctors estimated that the patients would live a median of 76 more days, but they told their patients they would live a median of 90 more days. So the doctor's own estimates of the prognosis were quite optimistic compared to actual survival, and then on top of that, they told their patients something even more optimistic. The third purpose of doctor-patient communication is making medical decisions. In one study, nearly every patient wanted all the possible information they could get, but only 2/3 wanted to participate in treatment decisions. Most patients thought their doctors should take the primary responsibility in making treatment decisions. So it seems like patients don't want to make ultimate decisions about their treatment, but they do want to fully understand why the doctor recommended one treatment over another. There are several ways to think about communication behaviors. The first way focuses on the content of the communications. There are communication behaviors which are instrumental or task-oriented, in which doctors give information, ask questions, give directions, or discuss side effects. The flip side is communication behaviors which are focused on care instead of cure. These are effective behaviors, which include things like being encouraging, being friendly, open and honest, showing concern, giving reassurance, and showing empathy. Another aspect of communication behaviors is whether they're verbal or nonverbal. A lot of effective behaviors are nonverbal. These are things like eye contact, voice tone, body position, etc. Lots of times, patients look for nonverbal leaks of what the doctor may be really thinking, and patients tend to be very sensitive to inconsistencies in verbal and nonverbal messages. Another aspect of communicating is dealing with personal information and privacy issues. There are all sorts of privacy issues when you're visiting the doctor. They ask you super personal questions about your moods and emotions and about your behaviors, particularly sexual behaviors, drinking, smoking, your last bowel movement, gas, and things like that. Doctors also touch you in ways that you wouldn't let most other acquaintances touch you. For example, during breast exams, testicular exams, prostate tests, and internal gynecological exams. Privacy issues are very tricky. For example, maybe you're comfortable with your doctor seeing you naked, but my guess is most doctors and patients would be uncomfortable if the doctor wasn't directing his or her attention elsewhere while you undress. If you're a patient in a teaching hospital, privacy gets even weirder because doctors do their rounds in a team. Another important aspect of doctor-patient communication is how controlling the doctor is. How much control does the doctor take over the conversation? Can the patient get a word in or not? In a highly controlled interaction, the doctor doesn't let the patient get too many words in, and it's very hard for the patient to ask questions. A low controlling interaction is one in which it's easier for the patient to participate. And finally, the kinds of words that are used is important to doctor-patient communication. Does the doctor use medical language or everyday language? Patients frequently don't understand even simple medical language. Also, patients may try to use medical language, but use it incorrectly, particularly in cases in which medical terms have different lay meanings. So, for example, depressed. Doctors say that they communicate in everyday language with their patients, but patients don't think so. In some studies, 25% of patients who had just been given a diagnosis and prognosis didn't understand the meaning of diagnosis, and 35% didn't understand the meaning of prognosis. Here are some common ways in which patients define common medical terms. If you want to pause the video and read over these terms, I encourage you to do so, simply because based on these definitions, I imagine most doctors have some pretty hilarious stories to tell about misunderstandings they've had with their patients. Studies show that there's quite a disconnect between what doctors think their patients know and what their patients say they know. In one study, 77% of doctors said their patients knew their diagnosis, but only 57% of patients said they knew it. 81% of doctors said they had discussed drug side effects with their patients, but only 10% of patients said they were told about the side effects of the drugs they were prescribed. And doctors rarely asked patients if they understood what they were being told. This happened only about 1.5% of the time. Okay, so those are some different issues in doctor-patient communication, but does any of this actually matter? Now I'll discuss the influence that doctor-patient communication has on patients' satisfaction with their doctors, patients' compliance and adherence with their doctor's recommendations, and patients' health outcomes. Patients are frequently dissatisfied with their doctors. 33% of patients are dissatisfied with their doctor, and the most common reason they cite is that they wanted more information. Patient satisfaction has been found to be highest when doctors effectively balance instrumental and effective communication, so when doctors do about the same of each. Satisfaction has been shown to be lowest when doctors focus primarily on instrumental communication and don't use much effective communication at all. One clear sign that patients are dissatisfied with their care is when they sue their doctor for malpractice. It turns out that being sued for malpractice has very little to do with how many mistakes a doctor makes. There are highly skilled doctors who get sued a lot, and doctors who make lots of mistakes who never get sued. And the overwhelming number of people who suffer some injury due to a doctor's negligence don't sue. What really matters most in predicting which patients will sue a doctor is how the doctor treats them on a personal level. This was made very clear in one super interesting study. The researcher tape recorded several doctor-patient interactions. Some of the doctors who were recorded had been sued for malpractice, and some hadn't. Then they compared the doctors who had been sued to the doctors who hadn't been sued. They found that doctors who hadn't been sued spent more time with patients, 18 minutes versus 15 minutes, used more statements of orientation. So, for example, first I'll examine you, and then we'll talk about your options, or I'll make sure to leave some time for you to ask questions. They also used humor more and laughed more. They solicited patients' opinions more, and checked to make sure the patients understood them more often. There was no difference at all in the amount of information they gave their patients or the quality of that information. So what you can see here is that there wasn't much difference in the instrumental stuff, but the key differences were all in making the patient feel like they were understood and making the patient like you. Another researcher took this another step further and found something pretty amazing. This researcher selected 4 10-second clips from these tapes and then content filtered them, which means that she removed the high-frequency sounds that allow us to recognize individual words. So what this leaves is just intonation, pitch, and rhythm, but no content at all. Then she had students rate those clips for their levels of warmth, hostility, dominance, and anxiousness. By using only those ratings, she could predict which doctors had gotten sued and which hadn't. This is remarkable because the student raters knew nothing about these doctors. They didn't know how skilled they were, or how much training they had, or what they were talking about even. All they had to go on was the doctor's tone of voice, and that was enough. If the voice sounded dominant, the doctor was more likely to have been sued. And if the voice sounded less dominant and more concerned, the doctor was likely to have not been sued. So in terms of patient satisfaction with their doctors and doctors' likelihood of getting sued, the doctor's nonverbal communication is very important. Another outcome that doctor-patient communication may influence is whether patients comply or adhere to their doctor's recommended treatment. Compliance with doctor's recommendation is very important if you're going to recover from an illness. However, compliance tends to be very low. This is sometimes referred to as medicine's dirty little secret. Consider this graph of the percent of patients that take all their medication, given the number of times per day they're supposed to take it. So for medications that are only taken once per day, 80% of patients manage to do that. But when patients have to take their medication 2 or 3 times a day, compliance drops to about 70%, and almost down to 50% when patients are told to take their medication 4 times a day. Patients fail to comply with their doctor's orders even in seriously high-stakes situations. 25% of renal transplant recipients regularly miss doses of anti-rejection medications, and 42% of glaucoma patients persisted in not adhering to their treatment even after losing sight in one eye. One particularly troublesome problem is with antibiotics. It's crucial to finish all of the antibiotics you're prescribed, even after your symptoms go away. If you stop taking them midway through your prescription, it could result in the creation of a drug-resistant strain of bacteria. Adherence is one outcome that is thought to improve with better doctor-patient communication. There is some, but not a ton, of evidence for this. Some studies show that when patients' attitudes are in sync with their doctors, so if they're compatible, then they're more likely to adhere to their prescriptions. However, when their attitudes aren't in sync, the medication adherence drops. For example, when patients have high personal control beliefs about their health, but their doctors don't share this belief, then patients are 50% less likely to adhere to their medication regimen. Other studies show a link between compliance and doctor behavior. Research has shown that adherence improves when doctors provide more information and use more positive language. Furthermore, patients tend to be more satisfied with and adhere to the instructions of doctors who are more satisfied with their jobs. One study looked at the effects of doctor-patient communication on whether patients got mammograms. They found that the only variable that influenced whether patients got mammograms was whether their doctor seemed enthusiastic about the patient getting one. If the doctor seemed enthusiastic, patients were more than 4 times more likely to get a mammogram compared to patients who thought their doctors didn't seem enthusiastic about them getting a mammogram. So the ways in which doctors communicate is quite important to patient compliance. A third outcome that might be influenced by doctor-patient communication is the health of the patient. There aren't very many studies on this, at least not many rigorous ones, but one study looked at communication factors and health outcomes and found that patients had better health outcomes when the patient exercised some control over the interaction, when the physician relinquished some control over the interaction, when there was more affect expressed by both doctors and patients, and when the doctor provided more information to the patient in response to the patient's requests for this information. Some research conducted with physicians at Indiana University has found that good doctor-patient communication makes a difference in the treatment of numerous ailments, including the resolution of chronic headaches, changing emotional states, lowering blood sugar values in diabetics, and improving blood pressure readings in hypertensives. So what is ideal doctor-patient communication? Well, different types of communication are probably better suited for different situations. So if you're making a treatment decision, you'll probably be more interested in your doctor's instrumental behaviors, whereas if you're learning very bad news, you may be more interested in your doctor's affective behavior. In addition, individuals differ in whether they want a lot of information from doctors or less information from doctors. Consider the following situation. Imagine that you're afraid of the dentist and have to get some dental work done. Please pause the video and write down the number that corresponds to all of the things on this list that you might do. Numbers 1, 4, 6, and 7 are things that monitors might do, whereas numbers 2, 3, 5, and 8 are things that blunters might do. So if you have more numbers associated with monitors, then you're a monitor. And if you have more numbers associated with blunters, then you're a blunter. Patients who want a lot of information are called monitors. These are the people who want to be aware of every little thing happening in their body. They're called monitors because they monitor their bodily sensations. People who want to be shielded from most information are called blunters. They try to distract and blunt sensations rather than feel them. In one study, a researcher divided people up into monitors and blunters and then randomly assigned them to get lots of information or just a little information about a procedure they were going through. She found that people coped best when the amount of information given to them matched their coping style. So monitors given a lot of information and blunters given only a little information were found to be the most relaxed and handle the procedure best. So with all this research on the downsides of poor doctor-patient relationships, what has research found that might improve these relationships? First, what should patients look for in an initial doctor visit? Well, the first thing to pay attention to is whether or not your doctor takes a seat. A good doctor will sit down and take time to listen to your symptoms and concerns. A doctor who remains standing and appears to be in a hurry may not be spending the amount of time necessary to adequately assess your situation. Also, you should be aware of doctors that don't take time to offer a formal greeting. If your physician doesn't even shake your hand, this is a warning signal that the doctor may lack the affective skills that have been shown to have important implications for patients' health outcomes. Next, what can we do to be smarter patients? First, and maybe most importantly, is not to be afraid of your doctor. If we're afraid of our doctors, then we basically end up putting them on some kind of pedestal. We don't ask the questions that we want to know the answers to, and we don't stand up for ourselves. We receive better care when we're not afraid of our doctors. There are also things you should consider when you book your appointment. First, you should call the office 30 minutes before it opens. This ensures that the right staff will be there to answer your questions. You should also make sure to clarify the type of appointment you need. So, for example, is it just an annual physical or a follow-up or something else? This way, you can get an appointment that's the right length of time, and your doctor will know why you're there to be seen. Finally, you should let the receptionist know what days and times work best for you. If a morning appointment can fit your schedule, try to take the first appointment of the day so that you can be seen before the office gets backed up. And finally, before your appointment, make sure you've prepared the answers to the following questions. What hurts you? Where does it hurt? How does it hurt? For example, all day long, or only with specific movements. Does it only hurt when you go upstairs, or does it only hurt when you go downstairs, etc.? And finally, what makes it better and what makes it worse? So, do certain medications affect your symptoms? Does aspirin help? Do any activities or foods affect your symptoms? And so forth. In addition to the answers to the questions on the previous slide, you should also bring a list of the following: past procedures and symptoms you've experienced, past medications you've taken, and your family medical history. It might also be very helpful to bring a friend, a family member, or someone else who can listen. Your anxiety levels may rise during an appointment, which can cause you to zone out. If you aren't able to fully listen to your doctor, then this may affect your ability to adhere to your doctor's instructions. A friend or family member can be your biggest advocate. So once you finally get to see your doctor, what should you do? Well, first, you should be an active participant in your care. You should take detailed notes. You should make sure to tell your doctor the truth. You should ask for clarifications. And you should ask your doctor what's wrong with you and what the timeline is for your treatment plan. You should also ask how you should communicate with your doctor via phone calls or emails, etc. And finally, you should make sure you know all of your treatment options. Finally, and maybe most importantly, make sure to get a second opinion. If your doctor is reluctant to help you get a second opinion, you should be a little concerned. It may just be that your doctor views this as a hassle, but for particularly difficult diagnoses, it's important to get a second opinion. Treatment plans change approximately 1/3 of the time when a second opinion is sought. That means that 33% of the time, your treatment changes after you've gotten a second opinion. Getting a second opinion from a different doctor might give you a fresh perspective and new information. It could also provide you with new options for treating your condition. You can then make more informed choices. Maybe the most important thing is to choose a doctor who thinks like you think. Just like finding a significant other, finding Dr. Right may take a few tries, but don't be discouraged. It's important to choose a doctor who matches your communication style and philosophy. That way, the doctor will be mindful of your preferences.